My name is Ben Kelemen. I'm a cardiology fellow at UC San Francisco. I just want to thank the panel for having me. It's a privilege and a real inspiration to hear and learn from everybody this week. And so I'm going to just present a case that's a little different than the typical acute myocardial infarction and cardiogenic shock that we see. So the patient is a 71-year-old gentleman with a past medical history of atrial fibrillation and not really anything else, who came to our county hospital in San Francisco, the general, with back pain and malaise. His EKG, which you can see, showed inferior and lateral ST elevations with precordial ST depressions consistent with inferior posterolateral STEMI. His initial troponin was elevated at 48 and rose rapidly thereafter. The rest of his labs were pretty unremarkable. His creatinine was mildly elevated. His white count was mildly elevated. Given presentation with STEMI, he was brought to the cath lab for coronary angiography, which showed a hazy thrombus, the hazy cutoff in the first OM branch with some other distal cutoffs as well, and otherwise fairly normal coronary arteries. It was difficult to restore flow in the vessel. They tried multiple balloon dilations, integral and drip, and ultimately performed aspiration thrombectomy, which revealed organized thrombus, and were able to place a stent and restore flow in the vessel. Here, based on this, it was felt that perhaps related to his AFib, he'd had a embolic phenomenon because there were multiple cutoffs, and he had fairly normal coronaries. Otherwise, he was hemodynamically stable and was returned to the CCU at this point. It's probably 8 or 9 p.m. My co-fellow was finishing the case. Overnight, he went into atrial fibrillation, no surprise, with heart rates in the 150s to 170s, and had progressive shock with rising lactate, renal failure, shock liver. He was requiring vasopressors and inotropes. At that point, I had taken over and came in and did an echo. He had a severely reduced LV systolic function with inferior wall motion abnormalities. And in this setting, he was cardioverted, thinking that perhaps the rapid rates were the problem without any improvement in hemodynamics. And so he was brought to the cath lab for, why does he have late presenting shock after his acute MI. His right heart catheterization on dobutamine and norepinephrine showed CVP of 11, a mean PA pressure in the 30s, a wedge of 25, and a cardiac index of 1.7 on dobutamine and norepinephrine. His PAPI did not suggest RV dysfunction. His echo didn't suggest RV dysfunction. His PAPI was 1.7. There was no step up to suggest a VSD on right heart cath, and there was no significant V wave to suggest MR as reasons for decompensation after his acute MI. So he was felt to have just LV systolic dysfunction related to his MI. He was intubated because he was somewhat confused, and we didn't think he could tolerate support. So he was intubated with some improvement in hemodynamics, actually, and then a balloon pump was placed. Our county hospital doesn't have access to other forms of advanced mechanical circulatory support, so we thought we'd start with a balloon pump and see how we did. And then he returned to the CCU. Despite this, though, he continued to have worsening, really mixed shock. He was febrile. His cardiac index remained less than 2 in the kind of 1.7, 1.8, despite dobutamine. And then he had progressive hypotension requiring multiple vasopressors, and he was actually treated for vasoplegia with some of the things that we use for sepsis, like high-dose vitamin C and steroids. But given just continued decline, the decision was made to transfer him to the tertiary care center at the Parnassus campus, thinking that he'd had cardiogenic shock and had progressed to the systemic inflammatory response that we see in cardiogenic shock sometimes. And we were going to pursue more aggressive modes of mechanical support. Unfortunately, just after we arranged to get him there and got him there, his blood cultures returned positive for Staph aureus. His initial echo hadn't shown he had had 2 actually transthoracic echoes. There had been a question of maybe a thromboelastoma on his aortic valve, but it didn't show anything like this. He had a TEE, though, that showed a large vegetation on the non-coronary cusp. Here you can see a nice 3D picture. And then there was no clear reason for why he'd gotten source for this. He had no history of IVDU. He had no history of valvular disease that we know of. His family did say it had a recent gluteal testosterone injection, so that was kind of our best thought as a possible source. So we did not place an Impella at this point, reasonably, but given progressive shock and mixed septic cardiogenic shock, the decision was made to take him for surgery. He had a surgical aortic valve replacement, and they placed a surgical Impella. And the operative notes report they actually had a large purulent pericardial effusion with fibrinous exudate that was covering the epicardium. and there was a 1 by 2 centimeter vegetation on the non-coronary cusp. They didn't see a perforation. There was concern for perforation on his TEE. Unfortunately, after this, he had improvement in cardiac function. We had refractory shock despite aggressive support, and care was ultimately withdrawn. He passed away. There are case reports of endocarditis causing embolism and acute coronary syndrome. It's quite rare. It was first reported on autopsy studies where they would note incidental findings of small emboli that was not associated with acute coronary syndrome. One large case series of 500 patients had a rate of roughly 3% of acute coronary syndrome. Usually, though, that was due to mechanical compression of the coronaries, not to embolism. So this is certainly an unusual cause of acute coronary syndrome. Thinking about management, there are reports of aspiration thrombectomy. Typically, we do that for things like atrial fibrillation, where you think there's a large thrombus burden, but it has been reported in endocarditis as well. It requires a high index of suspicion to think to do it, and very careful technique to avoid systemic embolism and stroke. We don't routinely do aspiration thrombectomy anymore. There are also, PCI is something people do when you have an occluded artery. It's certainly a reasonable approach, but there have been reports, you can see on the bottom left, of mycotic aneurysm formation after PCI in the study of endocarditis, although this is not a well-demonstrated phenomenon. Thinking about mechanical circulatory support, we'd arranged to transfer him. We were thinking to put in an Impella, support him through his cardiogenic shock. That would obviously be that large aortic vegetation would be a contraindication to a transvalvular pump like Impella. There are case reports of using ECMO as a bridge to surgery in endocarditis. These are two that I found, 2 small case series. The mortality is fairly dismal from what I can see and what I've read. In these cases, these patients are incredibly sick. There are some things coming out in Europe. This is not endocarditis, but there was a patient, there's this cytokine hemoabsorption that they use. And so there are some cases of combining that with ECMO as a treatment for this combination of distributive septic shock with cardiogenic shock, although I think that's largely experimental now. So I think this is an instructive case of an unusual cause of acute myocardial infarction and cardiogenic shock that would be managed differently than I typically think of AMI cardiogenic shock. I just want to thank the doctors that were involved in caring for the patient, the heart failure team, the interventional team, the cardiac surgery team, and for helping get the images. Thank you.
A great case. My question for you was, did he have any AI and you think he got worse with the balloon pump?
It's a good question. So there was some AI that was seen on the TE, and there was actually concern for a perforation of his of the leaf of the right coronary cusp. When they surgically examined the valve, they didn't actually see a perforation, so it's a little bit unclear to me. It was not severe on the TE. It was probably mild to moderate.
I have a question for the panelists. You were lucky that you didn't have Impella, but when you're in the cath lab, you have a patient with AMI, you found thrombus there, and the patient is in cardiogenic shock. I wonder what is the first thought on what support would you give to that patient? Because you are thinking this patient maybe is a clot from a FIV. So I think for most people who say, you don't have Impella, but that would be a very, like the first thought for a lot of people. So I think it's important that to take in account that if it's thrombectomy, you have a lot of thrombus there, where is that coming from? And that probably Impella will not be the best option for that patient.
Well, if I can it's not really a good answer perhaps to your question, but what I find particular in this case actually is the fact that this patient got into shock, right? Because it's actually quite strange that somebody who has just single vessel disease, occluded vessels, actually becomes so severely diseased. And although you have atrial fibrillation, but atrial fibrillation and just a small portion of the heart will not get you into severe shock. So at that time, I would say a lot of bells should be going off. Mm-hmm. And so, of course, you have to think about the support device, but I would say before you do a support device, everything needs to go into the diagnostics. What is going on? Why is this happening? Is there a rupture of the papillary muscle? Are we looking at something which is something that we haven't thought about, or perhaps exclude that you have thrombus in the left atrium? I mean, those are good thoughts, but you can't just go into shock with just one vessel problem.
That's a great point.
Yeah. We actually also reshot his coronaries because I was concerned that there was, you can't see very well in the picture, with something missing, you know, that we never really saw a very clear PDA, and it's PDA territory, so maybe there was some vessel that was not revascularized.